I'll turn it over to them for some brief remarks.
Yes, good afternoon. Thursday, and this is the week we don't have modeling, but I have Dr. Dirk Heyer, Ontario's Chief Coroner and Coordinator of the Provincial Outbreak Response, as well as being on the COVID-19 Vaccine Distribution Task Force with me. So I'll have some comments and statements and numbers to give you, and then I'll see if Dr. Heyer has any further comments to add after that. So as on Thursday, we see how has the week gone, what are we looking for as the week goes ahead, and how are we doing overall. So if we look at our data and information materials, we've added since Monday an additional 2,918 cases of COVID-19. That means we had 966 cases on Tuesday, 958 cases yesterday, and 994 cases today. 3 days under 1,000. And so we haven't seen that for a while. So in that matter, the new cases reported today, 298 are in Toronto, 171 in Peel Region. Ontario's current 7-day average for COVID-19 cases is 1,063, which is slightly lower than the same period last week when the average was 1,099 cases. We're also reporting an additional 38 deaths since Monday. And these are issues that, of course, we're always concerned and extending condolences to the family members who lost their loved ones. 11 of those deaths were on Tuesday, 17 deaths reported yesterday, and 10 deaths reported today. That means the 7-day average of daily deaths has now decreased to 15, down from 20 in the previous 7-day period. All these are, while being disturbing, are still encouraging directions. We'd like these down even lower. In terms of hospitalizations and ICU admissions, there are 649 COVID-19 patients in hospital. That's down from 687 last week. And we have 281 patients in the intensive care unit, a slight drop over last Thursday when there were 283 patients in ICU. So it has plateaued at this time. With respect to testing, while we have our usual dip of lower volume people going to assessment centers over the weekend, that shows up on our data on Monday, Tuesday, and Wednesday. Today we're back up with 65,643 tests and about the same volume pending for tomorrow. The positivity rate is down to 2.1%. The average positivity rate over the last 7 days is 2.5%, which is also slightly lower than the 2.7% in the previous week. To the issue of variants, this one we're watching, as our modeling table has given us lots of warnings about. We are today reporting another 678 confirmed variants of concern with the 501 mutation. Thus, sequenced so far, 644 of the so-called B117, formerly known as the UK variant, 31 of the B1351, previous called South African, and 3 of the P1 Brazilian variant. Based on analysis of the data, 75% of the VOCs are either associated with outbreak or close contact of a confirmed case. Only 16% have no known epidemiological link at this time, and they're still under investigation. 7.5% have a travel history related to their cases. In addition to officially confirmed cases of VOCs, variants of concerns, we are also now reporting on those COVID-19 samples that screen positive for the 501 mutation. As I said before, we're doing the 501 mutation, and then we gave you the data already on the actual sequenced ones up to this time. Knowing that there's a length of time between when the 501 is identified and the sequencing can take up to 2 weeks to undertake that fairly extensive testing. On March the 2nd, 23,347 samples have been screened for the 501Y mutation, and we have a positivity rate of 14.8%, or 3,462. When we look at the most recent data from February 24 to March 2nd, 5,598 samples were screened for the mutation. 1,452 came back positive, and that's a rate of 25.9%. So this accruing or increasing percentage is of concern to us as we watch and observe, and as we know the modelers said would recur in the end of February into the first week of March. So what does that mean? While overall our numbers are staying down below 1,000 for these few days, my guess is they'll rise up a little bit as our volumes go up in the next 2 days. And that may be reassuring as our percent positivity in the number that of the so-called older form of COVID-19 cases wane, the VOCs, or variants of concern, are rising and have a higher percentage. Thus far, those numbers are staying within some extent contained, but are increasing in percentage. So we're in that in-between period that Dr. Brown talked about, where we have to watch this as they rise above 25%, heading up to 30% of the samples positive. So we have to be wary of that and understand where that's occurring, noting also the more rapidity of their transmission and that we are concerned about because of the more ease they have to move from person to person in a very short period of time. So this is good news in a way that we're holding at the moment, and that's our challenge for the next number of weeks. Why? Because we are now picking up the pace on the vaccinations. And we did yesterday 30,409 doses. We are still waiting for more volumes of vaccine to come in. And maybe Dr. Heyer has some comment to make on that. We also heard from the National Advisory Committee on Immunization, which is our scientific body, review body for in Canada, and the recommendations go to the Public Health Agency of Canada, that they have agreed and came out formally to announce an increased interval between the first and second dose of both the Pfizer and the Moderna vaccines is extended up to 16 weeks, and that their efficacy or the function stays the same during that time. So that's reassuring, so that we can move to give a lot more people their first dose and deal with the second dose later. This means we can accelerate faster, and we have some advised timelines that we might be able to move up on the previous predictions of early fall to complete. We may have it even sooner than we had anticipated, and this is good news for all. But we still have to hold the other ones down while we undertake this task. So our task of maintaining our distancing, masking, staying home if you're sick, getting tested when you need to get tested, keep to your household, stay home if you do not need to go out. Limit your activities. Even if you are in a zone within the framework that allows you to access those activities, you should do so infrequently, only when necessary, and maintain all your personal precautions. Even if you're in the green zone, you still have to do the distancing. You still have to wear the mask. You still have to keep with your household. You still have to do proper hand hygiene. You still have to stay home if you're sick. Those are not released or relaxed in the lighter zones of green and yellow. You still have to be vigilant in those activities. By doing that, the thought is you keep the cases down, you maintain yourself at that level. You maintain access to some of those services that were closed in lockdown periods or stay-at-home orders or other restrictions at different levels. So there is a need for the collective action of the community. There's a need for those that are in high zones not to go out to the low zones. Because not only do you go out there, you may spread infection out there, but if you're in low zone, you go to high zones, you may pick it up and bring it back to your area. That affects your case counts in your area. That would put you up to a higher zone in the future, especially with the variants of concern. So we have to be still very careful as we wait for the vaccines as they continue to roll out. So that's our messaging. Stay consistent. Be aware of what your limitations are, but be very concerned about your personal actions. These are the ones that make the difference. And if you keep doing that well, if you are in a framework color that is open with certain activities, that can maintain it because you're doing it not only for yourself, you're doing it for your community members, the community you live in, You're doing it to keep the schools open. You're doing it to keep any impacts on the long-term care homes. Even if they've been vaccinated, we want to make sure we get that number right down. And we're seeing very encouraging signs on that in the last number of weeks. So this is all very helpful and supportive and indicative of that we're going in the right direction. But our work is not yet done. We have a lot more ahead of us. So I'm going to see if Dr. Heyer has any comments you'd like to make. Okay, so he said let's go over to the media for questions. So with that, over to Alex.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
From Antonella Artuso at the Toronto Sun. Please go ahead.
Thank you. Good afternoon, doctors. I wanted to ask if you can shed any light on the vaccination plans for people who are receiving home care or people who have mobility issues and can't get out to a clinic. I know that some jurisdictions are coming up with creative ideas to address this. Israel has a drive-through program. Texas just started a program where firefighters are going to people's homes to, as they call them, shut-ins, homes to vaccinate them. Have we got anything like that in the offing?
Dr. Heyer?
Good afternoon. Thank you for that question. And this is clearly an important part of the population. And what we're doing with the vaccine distribution task force is determining a variety, a multimodal approach and multiple ways to be able to deliver the vaccine. We had the early challenges with Pfizer and Moderna not being as transportable, and so we are working to develop better ways to do that. We've been working together with the home care provider organizations to think of plans and to think about how that we can do that. We've been focusing our attention, as you know, on those at the highest risk and ensuring that we provide vaccine to those, and that has involved people going to long-term care homes, retirement homes, assisted living facilities, and we're continuing to do that. And as we're doing that, we're looking for innovative approaches, as you've described.
Follow-up.
Thank you. This is a question about if you have had COVID-19, you're a member of the general population, should you be putting yourself at the back of the vaccination line, especially while the supply is an issue?
So that's a good question. I always like having Dr. Heyer here doing vaccination as the chief coroner. I think it's fantastic. We've had a team for a long time, and his help and assistance has been invaluable throughout this time, invaluable. When we're talking about it, as our data indicates, if you've had a COVID-19 infection, we've seen that some people will maintain some antibodies for a period of time. But after 3 months, that wanes considerably. So that is not a long lasting. Some can last longer than 3 months, but on the average, that is the area of concern. That sometimes they're asking in directions we're seeking from our scientific experts and our vaccinologists who are saying if you had an acute case of COVID, we would like you to wait a period of time before undertaking that vaccination because your current circulating antibodies may undermine the value of the vaccine when you get it and make it less potent. And so we've been asking for a number of places to look at maybe delaying 3 months from your diagnosis date until you obtain your vaccine. So I wouldn't say that puts you at the back of the line, but certainly you want to keep that in mind if you're coming forward because while you may want to get it as soon as possible, you would like to make sure it is as potent as possible and it works for you as best as possible.
Next question, and just a reminder to press star 1.
From John McGrath at TVO. Please go ahead.
Good afternoon, Dr. Williams. I'm wondering if you are able to speak to any sense of where Ontario would be right now were it not for the variants of concern. I mean, is it as simple to say that our daily case count and our number of active cases would be substantially lower, or do you suspect that some of that, 20-25% now of VOCs would have been original variant COVID in the counterfactual? I realize that I am asking you to sort of speculate here, but it's how much is this now driving the pandemic in Ontario?
So yeah, you're correct. If you look at the even the charts from Dr. Brown's presentation a week ago, and there's one that shows the regular COVID-19 going down as the variants start going up, and it's a replacement. And I think the encouraging part for us is that rather than one, we were worried mostly as they're coming down, the other one just would start ramping up fast on top of the other, and we'd be up to 1,500 to 2,000 cases by this first week in March. As a result, if you take these cases in the 900 range, 1,900, you know that, as I said, 30% of those are variants of concern. If those weren't around, we'd probably be closer to 600 a day, heading down in our tracking even better. And that would fit with Dr. Brown's graph and the modeling table as well. So this variant of concern is keeping that number up in the 900 range. But fortunately, it's not being additive to 900 on top. It's currently becoming more of a higher percentage of that number as the other ones wane and go down. So good news, the old one is going down. The VOCs, the variants of concern, are staying in there. What we don't want is them to rapidly escalate and put us back up to 1,500, 2,000, which they said if we're not careful, we could be back to that level up to 3,000 cases a day by the middle next week. But right now, I think everybody's doing well and we're holding. I'd like to be at 600, but I'm glad we're not at 1,500 to 2,000 with the VOCs replacing a reducing number of other COVID strains at this time.
Follow-up, and this will be the last question unless someone else joins the queue.
We're expecting an announcement shortly or imminently in the Health Minister's words about the vaccine rollout and the adjustment with the new guidance from NACI about the interval expanding to up to 16 weeks. That, if that in fact goes into practice, will be having a very large fraction of the population that is partially but not completely vaccinated in Ontario. And I'm wondering, how will that change the public health guidance in terms of things like the regional framework and what businesses will be allowed to open and what activities will be wise or unwise. Obviously, a partial vaccination is better than zero, but I'm just wondering if you can speak at all about where the advice is headed in the future.
Right. I thought you were going to go over to a Dr. Heyer question and then you move back into the framework. So I think it's a really good question because as we now will start to have significant numbers, we're not quite there yet. We're working on our target populations as we go through it as quickly as possible. We have really undertaken to do our most at-risk populations, and we've just about completed all that, both with, we kept to first and second dose in that group, and I've been very strong in recommending that we need to do that. I'm very concerned that even with some of the NACI data, these type of clients that are sometimes many nano and over 100 years of age with a lot of comorbidities, not a lot of studies have been done in the case control in these companies, so I'm very worried about their already limited capacity to produce a good immune response, and I want to make sure they have all the help they need to ensure that they have it and can sustain that. So that's being done. But as your question gets to, as we get more and more vaccine coming in, more and more individuals with one dose of vaccine in, with purported 80% with the Pfizer and the Moderna mRNA vaccines, giving them ongoing for at least for 4 months, 80% efficacy, means they're going to have a large number of people out and around as we go through the age groups, the priority groups, different ones down there, that make up a larger part of our populations in each of those communities and each of those frameworks. How will that be integrated into the various public health measures? We're having discussions even today with our leadership team on how might, could, and should that impact. What does that mean? Because it's a really great task to have. It's a good one to have to struggle with. And we want to work on that and how we might undertake to carry that out. Because when do you have enough coverage to do that, to make sure you can have some safety in there? And I know, unfortunately, some people are thinking, but for whatever reason, they're possibly being hesitant, not having it, and hoping that herd immunity will cover them. That's going to take quite a bit of time to get that up and running. So I have concerns that people would think really seriously about that, and when the vaccine becomes available, that you would make yourself avail yourself to that vaccine, because while we have a priority list, everyone's a priority. And it's a matter of how do we get to them as soon as we can, whenever we can, and to make sure we have maximum coverage as possible. And I'm not going to sound like General Hillier, but that's what he wants to have, as much in the arms as quick as possible, and everyone, if we can get there. So we will be bringing that into some consideration, because that means some of the congregate activities might be more flexible and allowable. That's all I can say at the moment. We have a lot of work ahead of us, but we're not at all inconsiderate of those, the impact, the good impact of a quality vaccination program that we're undertaking right at this time.
Next question.
From Nick Dixon at CP24. Please go ahead.
Hi, good afternoon, Dr. Williams. I have a question about a petition started by about 150, or signed by about 150 OHL players, asking when they may be able to get back on the ice. I'm sure you're aware a lot of these players have NHL dreams, and they're looking at the QMJHL, the NCAA, USHL, and the WHL are playing and playing safely. And, of course, NHL players are playing in Ontario. Have you looked at the OHL? What are the chances of the OHL players getting back on the ice and playing hockey?
We've had the OHL on our discussions for an extensive period of time, and much like we have with the NHL, and then more recently the AHL and the WHL and different ones, because what we've been wanting to have is that they would emulate as much as possible the successful NHL model, if you may. And you've noted the success of that. Somewhat better, I think, so far in performance in the Canadian League than in the American sector, but of course they're doing a much higher level of exposure with a lot of community transmission in some of the U.S. states where the teams are located, and they have their challenges there. So that involves a fair amount of infrastructure, a fair amount of investment and cost that, of course, professional leagues like the NHL can handle. The players themselves are businessmen and women in the WHL, and they know that, and they have that ability to broker that because they have as much invested interest as does the league and in their career paths in that. Our concern in the AHL are the same because they are professional. The OHL we're concerned about is that we have these young men mostly, some young women too in the other leagues, have great aspirations, but they don't have the same resources to ensure they have the same safety standards in there. And what I'm very concerned about is that, as we've seen with some of the cases of COVID, while in young people it may seem like a benign issue, we're getting more and more cases of so-called long hauler syndrome. And I would hate to have a young potential NHL star be sidelined career-wise because of a COVID case. I know their drive is to play and to want to play at all costs, and that sometimes those younger men have a sense of invincibility. But to get a virus because we were not careful with them would be a terrible waste of all that investment and time. So we're hoping we can get that up and running. Of course, there's many ways we can try and handle that. So while I can understand their dreams and endeavors, I don't want those shattered by a case of COVID. And so we want to see if we can get that up and running as soon as we can, and working with examples from our professionals who also see these as future players and candidates coming into the league. And so they went through that and they want it done properly and carefully. So we'll continue our discussions, hoping to get something, if we can, that's safe, assured, and consistent, and protects their, not only their career, but protects their health and that of the family has invested so much in it up to now.
Follow-up, and this is the last question.
Thank you for that, Dr. Williams. My follow-up question, and I apologize, I joined this a little bit late, but I'm wondering if you've said or if you have any plans to make a recommendation. We've heard in the last couple of days that both the medical officers of health for Toronto and Peel region suggesting they should get back under the framework in gray. Is that the plan? Is that likely going to be your recommendation?
Yeah, in our process, we we have discussions with all the MOHs that have any potential movement within the framework. And as you've alluded to, we knew from before that 3 of the health units that have been out of the framework up until now in the stay-at-home order, namely Toronto, Peel, and North Bay, will be re-entering the framework as of midnight on Sunday coming up. The question is, where do they enter the framework into? And that is a discussion we've already had with in the case of all 3, and with other MOHs and framework movements. So we have those discussions, we update the data accordingly, and it's not just a clear metric of where they are at the moment when they come out of a framework, where are they progressing? And we have been concerned, as we raised to their attention, that their numbers on 2 things that are I'm a bit worried about up till now. One is that their percent of positivity, I should say their case numbers per 100,000 had been coming down. Toronto has leveled, easing, going up, back up a little bit, and Peel is going up again. And their R effective is going back up again, and their positivity is dipping back up again. So that is that dip that we talked about with the modeling table. Is it a preemptor towards going up? And we do not want to see that hockey stick type rapid exponential curve, because these are both of our highest population density areas, and we're very worried about them. And as well, there are variants of concerns in our database. While on a percent basis is less than some of our smaller ones, these are not insignificant numbers, and we see those going up fairly steadily, and that is very concerning. And we have some clusters, both of the South African, the B1351, as well as the P1 Brazilian, going up in both those areas. So we want to be cautious at this time. And so we've made some recommendations to them, and I think we'll see. I've heard their comments back, and we're going to be making some comments and discussions. We've already given some early information to the Cabinet, and we'll give them the final data points to the Cabinet tomorrow morning, and they will make a decision that would then be announced on Friday and effective midnight on Sunday, before 12:01 on the 8th of March. So that's an ongoing dialogue, not just with them, but with all the MOHs that are being impacted with any changes at this time, and that's part of the dynamic analysis and consultation with each one of our medical officers of health in the province.
Thanks, everyone.